I think we shall go on to our next speaker. Our next speaker is Dr. Priya Narang, who's leading her NARANG Eye Center at Ahmedabad, a very dynamic, capable surgeon with great national and international standing, and very impressive textbooks in ophthalmology to her name, and a lot more. And she's going to take us a different path, reading a single field printout with advanced vision analyzer, which is something would become a pet equipment for many in their practice. On to you, Dr. Priya.
Good evening, ladies and gentlemen, and thank you so much, Dr. Chitra, for having me here. And I'm really honored to be here. And I'll be presenting. I'm in this symposium of glaucoma specialists. I'm just putting forward a new kid on the block. So, well, I'll be talking about the advanced vision analyzer, which has been recently. It has been there in the market for quite some time. It's a United States FDA-approved device. So many of the panelists here, they must have taken a trial of this, but for the benefit of the audience, I'll just like to go through the device in itself and then come up to the visual fields. So, well, this is we just got into publication with this in the American Academy, and this is the peer review paper which has come out. Moving ahead with this, it's as the name suggests, it's the virtual reality perimeter, and you have a head-mounted device. You wear it on your head. It's just like a gaming system, and you wear the head-mounted device, and then you have the test response. You have the test control device, which you can see on the left side, and the patient response pattern, which is connected by the wire to the device. And there is a fourth aspect to this, which is a backend server, which is the cloud, wherein all the data of the device and everything is being stored. So I'll just play this a very short video of how this device is actually it is. This is the head-mounted device, and it has an adjustable headband. It can be placed on the head of the patient, and this is the test control device, wherein you can feed all the data inside. You can feed in the patient details, everything inside this. This is how you go ahead. You can choose the test pattern and the strategy and other details. This device, it has its, there is an eye tracking system in the device also that helps you to track the movement of the patient. You can adjust the interpupillary distance. You can perform the test in the reclining position, and this is how you actually see on the test control device the gaze tracking system of this device. This is how it actually looks like when you're going ahead with the test. So to brief up with this device, I just say that currently it hosts the 30-2, 24-2, and 10-2, and the algorithms, they have been specifically designed for this device. It is the screening is known as the laser fast, and the standard algorithm is it goes ahead with the CETA standard, but it's a different strategy that they have incorporated into this. It has it closely resembles to the ZEST, that is the CP estimation, but it also has a staircase system. So it's a combination of this system which is incorporated into the standard algorithm, and then there's also full threshold algorithm which has been incorporated into the device. So just to go ahead with the key features, the basics, it's a white on white perimetry. You can you can place the corrective refractive error, you can correct it, you can place the corrective lenses, adjust the interpupillary distance. You have an eye tracking system. Usually the stimuli that are presented are the Goldman size 3, and it has a cloud-based storage system, which I told you before. And many catch trials to ensure a reliable test, the catch trials have been incorporated into the device, and continuous checking of the false negative positive and the fixation losses has been incorporated into it, and these are the test strategy checks which are there. The normative database as of now, they had incorporated about 174 eyes, which is still being more, and that is how the parameters about the age corrected mean for all test points, etc., has been calculated for this. The assessment of the blind spot location has been done, and it has been found to be quite accurate for this device, along with the test-free test variability. The results are quite reliable. So now this is coming up to the main thing, is the visual field reports that you are seeing now on the screen. So this is how the visual field report actually looks like. Now what you see on the left side is the doctor's report, and on the right what you see is the patient's report. So on the doctor's report, it is almost similar to the Humphrey. So the interpretation of what Dr. Sinha just said about Humphrey, it goes along with this device. It has been, an attempt has been made to make it as simple as possible, because although Octopus is being used quite widely, but Humphrey is one of the most commonly used devices. Hence, the reliability parameters of this device and the each point-wise testing of this device has also been done and compared with the Humphrey. So that is why I've just put forward this. And now, as we go ahead with the interpretation of this, if anybody is well versed with Humphrey, the surgeon is not going to actually struggle with the interpretation of the visual field report. There is, as you see on the left side, you have an algorithm, the kind of test, the 24-2, which has been done, the fixation monitoring and the reliability indices, the kind of stimulus, the strategy, the corrective lenses, you have the grayscale, you have the total deviation. It's almost similar or absolutely similar. You have the mean deviation, glaucoma hemifield test, visual field indices, pattern standard deviation. So this has been beautifully explained right before in the second talk by Dr. Sinha. So I don't go ahead with those details. But yes, this is how it looks like. And on the right side, what you're seeing is the patient's report. Now, this is a very important thing because, it becomes very easy for the surgeon to explain to the patient what actually the patient's visual fields actually they look like. And here you have a beautifully drawn Taj, which shows, depending upon the kind of the glaucomatous error that the patient has, that how actually the patient is seeing the world and how actually important it is for the patient to continue with the treatment. It becomes really very convincing to treat to the patient, and the patient compliance also increases once they try to understand and realize that what they're actually the visual field should be and what actually it is. So this is how it actually looks like, but yes, it has to be correlated clinically because it goes ahead with that. The second most important thing with this is that, being this, the reports with this device, the second most important thing that I would just like to emphasize right here in front of everybody is that, there is a continuous update system which goes on with this device. This is from the back end. So like you are connected to the internet, and then, the kind of updates that we keep on getting on our iPhones and on other smartphones, you keep on updating from iOS 13, 14, 15, something like that. So you have a continuous update coming up from the backend, and any new thing that comes up into the device comes up into your device. I mean, you are continuously on the radar of the newer inventions or strategies or whatever is being built for the device. You are into it already. So to begin with, we have started with this device with the virtual field. So that's why, with the field reports, but this device is not going to get limited to the field reports itself. There will be many more things which we plan to come up with this device. Anyway, as of now, what I'm here to talk about is these are the visual field reports. And yes, I would just like to say that just being a newer device which has come up, the point-wise sensitivity for this has been done on 24-2, and this is how it actually looks like. What you see in A and B is the A is the AIOS, and on the B in normal individuals is the individual sensitivity reports which have been collected on HFA. So there is a difference of about 2 decibels if you take in normal patients, and the same thing is with the glaucomatous patients, the E and F. What you see is for the glaucomatous patients, E is AIOS in glaucoma and F is HFA in glaucoma. So there is this difference of 2 decibels which is coming up into this, and it remains as it is irrespective of the patient being a glaucoma or this one. So the difference is stable. So the reports that I'm trying to emphasize is the reports which are generated by this device are quite reliable. So I'll just highlight what analysis has been done as of now. These are the for the mean sensitivity, the comparative values on the blind enhancement and the linear regression values are these, and they fall into agreement with each other. This is for the mean deviation and the pattern standard deviation. There is an ongoing development for this device which is still going on. That is with the progression analysis and the EMR integration, which is going on. So the another advantage with this device is, the first advantage is that it's a portable device. It's easy. All those people who are accustomed to doing a visual field test, you can do this visual field test. Accurate detection of visual field defects. It's cost effective, almost 1/3 to 1/4 the cost of what a standard perimeter would cost you. It costs you less than that. The most Yeah, just a minute. It's just ending. The another most important thing is that it's a portable device. You can share this device amongst various surgeons across in the same city, and you can do it. You can do, if you are into a peripheral rural center, you can do a visual field. You can share it with one of your best glaucoma friend, and they can guide you that, okay, this is the status of your patient and this is how it is to be done. So it's really very helpful in those strategies, in those kinds, and you can do it anywhere, wherever you want. You don't need a dark room for this. You can do it anywhere. So that is one another important thing. It allows you a lot of postural freedom. The weight of that head-mounted device is around 500 to 600 grams, so that's quite effective. I mean, it's not much of a burden in patients with neck deformities or etc. Especially in post-COVID situation, you can do it with masks on. So that is, I just gave a brief about this device and about the visual field report, how it actually looks like with this device. Thank you so much.
Thank you very much, Dr. Priya, for giving us all the salient features here. There's also one advantage is you can wear your own glasses, so you do not have the rim defects which can occur when you're using a trial frame. Murli, since we do have it in some of our centers, can you throw light on how both Humphrey and Eliza show significant correlation in normal and glaucomatous patients?
Yes, madam. We have this device in our OT and other centers also. We have seen that patients who have been referred from OT and this thing, almost everything correlates. So that way, I mean, it's a cost advantage, but what behoves the company is that, like in Humphrey, you have the database displayed on their website. Whereas, I mean, the number of patients and what is the mean age, all that is like displayed on their website. That is not the case with Elisar or with the other parameters. So they have to be a little more transparent on that database so that we can also.
My own worry, Dr. Murli and Dr. Priya, is that this is, of course, an emerging technology, holds a lot of promise, but then the technology needs to be stable for us to have, use it effectively in our patients for follow-up, for progression, because we're not talking about 1 year, 2 years, we're talking about a long period of time. So till the technology becomes stable, what is the place of this virtual reality based visual field?
The future of this device is quite bright. Am I supposed to?
No, but right now we don't have a. You yourself said that it is being updated and you get the updates. It's something which is changing, just like nerve fiber layer analysis was changing in the initial period.
Let me make one thing clear. The first thing is, it is changing. That I don't mean that we are changing the algorithms. We are not changing the algorithms. Secondly, what we are doing is update means it is something like previously the patient report was not there. That has been sent it up. It's not that the basics of the device is going to change. The basics of the device remains as it is. If there is any newer development, that keeps on getting added to the device. So that is the advantage of it. That's what I mean. I don't mean that they're changing algorithms or anything of that kind. So your diagnostic application remains as it is, and it is quite valid because decibel differences they come up with every device, madam. So it's
I'm not questioning the validity of your device. I mean, these devices are also being tested, but for the end user, it is the stability of the platform and the company which matters. Okay, so this is an emerging field. There may be 10 players in the field right now. Okay, and there are only few which are going to stand the test of time, and those are the ones which will come to stay. And we will definitely use this technology. So in the meanwhile, I don't think this can replace a Humphrey or an octopus perimeter. It is like an add-on.
Yeah.
For a screening or something.
First thing, let me get some facts clear about it. I'm not asking anybody to replace it with a Humphrey or replace it with it. Humphrey has been there in the market for maybe, I don't know how many years it has been there in the market, right? And we all have faith in it. If you ask me, even I have a Humphrey with me, and I also have an AIOS with me, and I am continuously evolving. I do agree to the fact that what you're saying, you have to prove yourself. That happens in every field. You have to prove yourself, and you have to stand the test of time to be where you really want to be. So that's a different aspect. The aspect which I am trying to put as of now today is that comparing the visual fields which are coming up with Ava and which are coming up with Humphrey. That is it. And as of now, as of today, whatever studies and whatever we are doing it, and they're coming up with a major studies right now, which I cannot right now put forward in front of everybody, but then it's absolutely bang on target. So yes, but I do agree for everybody to put into faith, you might take some time. So that's it.
Because the common question that general ophthalmologists ask us is that, can I buy this and not buy a threshold perimeter? You know, I am a smaller practice. I want to buy a perimeter. So can I invest in this virtual reality perimeter?
I think they can buy. They can buy.
Okay, the panel, can we have the panel's input on this, sir? Dr. Krishnadas, Dr. Chandrima, please.
Chandrima, you want to say something?
Yeah, so wonderful talk and interesting as well. But I suppose for known glaucoma patients, we need to still stick to the Humphrey and the octopus. And maybe for screening, as of now, we can use this. If you just want to screen a patient before cataract surgery and see what the field is like, that's fine. But I think for known glaucoma patients, we definitely need to stick as of now to the Humphrey and the octopus, because we need more studies, we need more evidence-based studies, so that we can actually, like, go forward and put this on the protocol as of replacing Humphrey and the octopus.
Yes, absolutely. Study-based evidence has to be there.
Actually, the good news for your Priya is that Humphrey has a database of about 422 odd people, whereas ELISA already has nearly 200. So, and that is an Indian population. So if you really work on it and get the progression analysis done very methodically, we would have greater inputs for our own Indian patients.
Yeah, we are coming up with major breakthroughs in this device.
May I add a point if I can, Dr.
Yes, yes, Dr. Modi. Yes, yes, for sure.
Yeah, actually, this ELISAR, I have been using the ELISAR machine for about 3 months for a demo, and I'm really impressed with the machine.
Yes.
Since whatever I have got of any patient who's been doing on Humphrey or the octopus, they get similar results with the ELISAR.
Yes.
But having said that, for progression, obviously I can't use it because I'm a full-fledged glaucoma practice. So for a full-fledged glaucoma clinic, probably it is not of great value. But for a single practitioner, if you're running a community center, if you just want a perimeter instead of doing confrontation fields, I think this is definitely the way to go, such a low-cost option. One. Second is, we did actually a study in our general hospital for neuro-ophthalm patients, people who can't sit up on a slit lamp, who can't sit on a perimeter, who can't even sit up to do the perimetry. The bedside perimetry for neuro-ophthalm and stroke patients, we did find this machine was amazing. You can simply put it on the patient as the patient is lying down and then do the field test. So for neuro-ophthalm, it's a wonderful device. And some of the children took to it so quickly, because the virtual reality actually is so nice for children and juveniles. So all these kind of situations, I think you'll probably find a place for this.
Yeah.
Yes.
I agree. Yeah.
There's a value to this whole talk. Thank